Welcome to the Deep Dive, your shortcut to being truly well-informed.
Hello.
Today we're plunging into a topic that touches millions of lives globally, a chronic condition that presents, well, a unique, evolving challenge in its management, multiple sclerosis.
That's right. And to truly grasp the nuances of MS care, maybe let's start by walking through a real-life journey. Picture this. An 18-year-old man, a promising young adult who's just received an MS diagnosis.
Okay.
He's experiencing significant left-sided weakness and a real struggle with coordination. His brain MRI, it shows lots of active areas of inflammation, indicating the disease is actually quite aggressive.
Wow, that's a lot for anyone, let alone someone that young and their family to take in.
Absolutely.
So when it came to treatment, this patient and his parents, they initially had a strong preference, right?
They did. They leaned towards what's called an escalation approach, meaning starting with a, let's say, milder treatment, prioritizing safety above everything else. And this was even though his doctors had clearly laid out the very real risks, the potential for long-term disability if the disease wasn't quickly brought under control.
It's completely understandable, though, that desire for safety, especially with a new diagnosis.
Yeah.
So what did he start with?
So he began treatment with interferon beta. That's considered a modest efficacy agent.
Okay.
It offers a more sort of gentle approach to modulating the immune system. But, well, despite that cautious choice, his disease continued to be aggressive.
It didn't work well enough.
No. Within just a few months, he was experiencing frequent relapses, and new spots kept appearing on his MRI scans. You could see the active inflammation. That initial strategy just wasn't cutting it, wasn't effectively controlling the disease.
That's plan B.
Right. They tried another route, moved to a second modest efficacy agent, glatiramer acetate, hoping, for a different outcome. But once again, the disease persisted. The relapses continued, new active areas showed up on his MRI. He even developed some specific neurological issues like internuclear ophthalmoplegia.
Which affects eye movement.
Exactly, eye movement and coordination. And even bladder and bowel dysfunction started. It was becoming, well, undeniably clear that this milder approach wasn't strong enough for his MS.
And this is where things shifted.
This is where the dynamic nature of MS management really comes into play. Despite his initial fears about stronger treatments, and importantly, after thorough testing confirmed he was negative for the JC virus antibody.
Which is key for certain drugs, right?
Yeah.
Lowers the risk of that serious brain infection, PML.
Precisely. That confirmation significantly lowers the PML risk for certain therapies. So with that reassurance, he eventually accepted a highly effective treatment. Needlesumab.
The one he'd initially feared.
The very one.
And what happened then?
The change was, well, it was dramatic. His disease activity, both the new symptoms he was experiencing and the inflammation seen on MRI, it came under control.
That's fantastic.
Yeah, he saw marked improvement in his neurological examination, too. This case, it just perfectly illustrates the core duality we're diving into today.
Great.
The intricate balance between these powerful disease-modifying therapies, DMTs we call them, designed to slow or stop MS progression.
Yeah.
And the equally vital strategies for managing the day-to-day symptoms, the things that profoundly affect a person's quality of life.
So these two pillars of care, disease modification and symptomatic management, they have distinct immediate aims, you could say.
They do, but they are deeply, deeply intertwined in the real-life journey of living with MS, where finding the right balance for each individual isn't just important, it's really key to living well with this condition.
So settle in, because today we're going on a deep dive into that crucial interconnected duality in managing multiple sclerosis. DMT strategies versus holistic symptom care, finding the right balance for you.
Let's get into it.
Okay, let's unpack this in our first segment. Treating the disease, navigating disease-modifying therapies, DMTs. The moment an MS diagnosis is made, it immediately raises critical questions about treatment strategy. And what's fascinating here, what underpins everything, is something called shared decision-making.
That's exactly right. And shared decision-making, it isn't just, a buzzword, it's a genuinely collaborative process. Your healthcare provider works closely with you, the patient.
How does that work in practice?
Well, it's about truly incorporating your individual values, your preferences, your lifestyle into an evidence-based discussion about all the available treatment options. The goal is to reach a joint treatment decision that you both feel good about.
And does it make a difference?
Oh, absolutely. Studies consistently show that this approach leads to better adherence to treatment and ultimately better long-term outcomes in MS care. It's really about being partners in your health journey.
And this is so important because, well, as you might expect, patients and providers don't always see things exactly the same way, do they? Their priorities might differ slightly.
That's true. Large studies have shown, for instance, that patients often prioritize reducing disability progression, minimizing the risk of side effects, and improving their relapse rate. Makes sense. But they also put a lot of weight on how bothersome certain side effects might be, like the day-to-day impact. And interestingly, they tend to deprioritize changes seen on MRI scans compared to what, say, a medical panel might focus on.
Okay, so what do providers typically prioritize then?
Providers, in contrast, might be more inclined to prioritize the reduction of relapses and new MRI activity. They might weigh that higher, even over the potential for certain serious adverse events, just given their understanding of long-term disease progression.
And that difference in perspective really highlights why having a separate, dedicated treatment visit is so important, doesn't it? Not trying to cram it all into the diagnosis appointment.
Exactly. It gives you, the patient, the necessary space and time to process all of this new, often overwhelming information without feeling rushed into making a decision. You need time to digest it.
Right. So once those shared goals are established, what are the actual treatment strategies for relapsing MS? You mentioned the escalation approach earlier. What's the alternative?
We're talking about two main philosophies, really. The escalation approach, as we saw, and the early high-efficacy approach.
Okay, tell us about escalation again first.
The escalation approach is precisely what it sounds like. You start with a modest to moderate efficacy agent after diagnosis, a gentler start.
And then you watch closely.
Then your doctor carefully monitors you for any signs of the disease breaking through the treatment. This monitoring can be clinical, so new symptoms or relapses or radiographic.
Meaning MRI scans?
Right, new spots of inflammation showing up on an MRI. If that breakthrough activity is identified, then you escalate to a higher efficacy therapy.
So this strategy, it inherently prioritizes safety, right? Starting lower, moving up only if needed.
That's the core idea. It's often favored by patients who are, understandably, wary of the potential side effects of stronger medications right off the bat.
Okay, and then the other side of the coin, the early high-efficacy approach.
This one is more aggressive from the outset. The goal here is to rapidly gain control of the inflammatory activity.
Well,
By initiating agents with robust effectiveness, ones known to be strong at reducing relapses and new MRI lesions right at the time of diagnosis.
so hitting the disease hard and fast.
Exactly, trying to prevent that early damage before it accumulates.
Now, what does the evidence actually say when you compare these two strategies? Is one clearly better?
Well, it gets a bit nuanced there. Retrospective studies, so looking back at existing patient data, have suggested that an early high-efficacy approach might lead to a reduction in disability progression, maybe even a lower chance of converting to secondary progressive MS later on.
But there's always a but with retrospective studies.
There often is. By their very nature, these studies can be tricky. For example, sometimes sicker patients might already be the ones started on more aggressive treatments.
So it makes it hard to tell if the better outcome is truly due to the early aggressive treatment itself.
Or simply because those patients might have progressed more severely regardless. It's hard to untangle cause and effect perfectly when you're looking backward.
Makes sense. What other evidence is there?
Well, meta-analyses, which combine data from many different studies, do suggest that getting treatment started earlier in the disease course, regardless of the specific drug, may predict a better treatment response overall. Starting early seems important.
All right.
And data from large international registries, like MS-BASE, indicates that patients who were exposed to a high-efficacy therapy within 2 years of diagnosis had better disability outcomes than those who started later.
So getting to an effective therapy quickly seems key.
Yes. But, crucially, this data doesn't definitively distinguish between starting early with a high-efficacy drug versus a rapid escalation to one if the initial milder therapy isn't working.
So it supports either hitting it hard early or starting milder, but being ready to switch fast if needed.
Pretty much. It suggests getting to effective control within that early window is what matters most for long-term disability outcomes.
Which brings up that question I had earlier. Have you ever wondered why some patients start on higher efficacy drugs right away, while others take that wait-and-see escalation approach? It really depends on these strategies, doesn't it, in the patient's specific situation.
Absolutely. It depends on their individual disease activity, their risk tolerance, like we saw in our opening story, and that shared decision-making process.
So to really nail down which strategy is definitively better overall, we need those head-to-head trials.
And those trials are, in fact, ongoing right now. The Treat MS and Deliver MS trials are specifically designed to compare these strategies directly in a randomized way. Their results will be incredibly important for guiding future treatment decisions. We're eagerly awaiting those outcomes.
Okay, so let's say a treatment is chosen, but it isn't working well enough, or maybe the side effects are too much. When do you actually switch DMTs? We saw this happen in our opening vignette.
Yeah, in large observational studies, the most common reason people switch DMTs is indeed a lack of efficacy. The medication just isn't controlling the MS adequately.
And the second most common reason.
Concerns about tolerability. The side effects are just too difficult to manage day to day.
And when patients do switch, is it better to just try another drug in the same class or step up?
Studies generally support that moving to a higher efficacy medication rather than just switching sideways to a different agent of similar efficacy but maybe a different mechanism is more likely to lead to better MS disease control.
Especially looking at relapse rates.
Exactly, especially as measured by the annual relapse rate. If something isn't working, you often need to step up the power, so to speak.
That makes intuitive sense. And you mentioned the concept of treatment success itself has kind of evolved, hasn't it? From older scores to this idea of NEDA.
Right. It used to be measured by things like Rio and modified Rio scores, older ways, less comprehensive. But now the conversation really revolves around no evidence of disease activity, or NEDA.
NEDA. What does that actually mean in practice?
NEDA is a composite goal, kind of the gold standard now. NEDA 3 means the absence of three key things.
Okay, what are they?
1, no MRI disease activity. That means no new or growing spots or active inflammation that lights up with the contrast dye.
Got it. No new MRIs pop. 2.
2, no clinical relapses. So no new or worsening symptoms lasting at least 24 hours.
Okay, and 3.
And 3, no confirmed disability progression. Your overall disability level isn't getting worse.
No MRI activity, no relapses, no disability progression, and EDA 3.
That's it. And for those who really want the highest bar, there's even any day 4.
What does that add?
That adds a fourth component, the absence of accelerated brain volume loss. So basically trying to minimize the loss of brain tissue over time, which can happen in NAD.
Is achieving 80 actually common? How realistic is it?
Well, achieving and maintaining NAD, especially NAD3, is actually quite challenging. For instance, in one large study, the Contiuum cohort, only about 8% of patients managed to retain NAD3 status after 7 years.
Only 8%. Wow.
It's tough. However, achieving NAD3 at just 2 years into treatment was highly predictive of having a lack of disability progression at 7 years.
So even if it's hard to maintain long-term, hitting that NEDA3 mark early on is a really good sign for the future.
Exactly. It highlights its importance as an early indicator of treatment success and suggests a better long-term prognosis.
And this brings us right back to our opening case study, doesn't it? The young man.
Precisely. That patient, who started with modest efficacy, had persistent disease activity clearly visible on his repeat MRI scans. It was that MRI surveillance, that repeated checking.
That gave the evidence needed.
Yes, it provided the necessary objective information to guide him, despite his initial low-risk tolerance, to eventually transition to a high-efficacy treatment. And that ultimately improved his long-term prognosis.
So MRI isn't just for diagnosis. It's a critical tool for monitoring treatment effectiveness throughout the journey. Ideally reviewed how often?
Ideally reviewed yearly to track things closely.
Okay. Let's get into the DMTs themselves a bit more. Since 1993, when the first one was approved, the options have exploded.
They really have. We now have 19 FDA-approved DMTs, acting through 10 different mechanisms of action. It's incredible progress.
But there's a general principle, right? More power often means more risk.
That's a good rule of thumb, generally speaking. The more effective a DMT is at controlling the disease, the greater its associated potential risks often are. It's a constant trade-off, a balance between power and safety that needs careful consideration for each person.
So what are some of the big categories or general considerations we should know about these different classes? What makes them distinct for someone trying to understand their options?
Okay, broadly speaking, The older treatments like interferons beta and glatiramer acetate, they're considered immunomodulatory.
Meaning they adjust the immune system.
Yeah, they work by broadly calming and adjusting the immune system, sort of fine-tuning it. Most of the other newer DMTs are considered immunosuppressive to varying degrees.
So they dampen the immune system more directly.
Right. Which means for patients on these immunosuppressive DMTs, careful monitoring for infection is essential. Appropriate cancer screenings are also important.
And vaccines?
Good point. Live or live attenuated vaccines, the ones with a weakened form of the virus, are generally not recommended because there's a risk of actually getting sick from the vaccine itself when your immune system is suppressed.
What about other vaccines, like the COVID mRNA ones?
Recent studies, particularly with the COVID-19 mRNA vaccines, have shown that certain DMTs, especially things like S1P receptor modulators and B-cell depleting therapies, can significantly lower your body's ability to produce protective antibodies in response. Vaccine response can be blunted.
Okay, let's maybe highlight just a few representative examples from these different categories so listeners get a feel for the range. Can we start with the oldest class?
Absolutely. First, the interferons beta. These are the originals, approved starting way back in 1993. So they have a very long, well-understood safety track record.
How are they taken?
They're delivered via injection. They work, as we said, by broadly dampening the immune response and reducing inflammation. The exact mechanism isn't fully pinned down, but that's the gist.
And effectiveness.
Their efficacy is more modest compared to some newer agents, but they still significantly reduce annual relapse rates by about 18-32%. And slow disability worsening by 30-40% compared to no treatment. They also cut MRI activity by around 80% versus placebo.
What about side effects?
Common side effects often include flu-like symptoms, especially early on, but these usually improve over time and can be managed with over-the-counter pain relievers. Less commonly, things like liver issues or low white blood cell counts can occur, so monitoring blood tests is needed. Importantly, they aren't associated with opportunistic infections or cancer.
And pregnancy. Vaccinations.
They are considered non-teratogenic, meaning safe in pregnancy, generally safe for breastfeeding, and they don't typically interfere with vaccine responses.
Okay. Moving on to a different class, maybe the oral ones. Fingolimod was the first, right?
Right. The sphingosine 1-phosphate S1P receptor modulators. Fingolimod was a game changer as the first oral DMT. Others in this class include siponimod, ozanimod, ponesimod.
How do these work? It sounds complicated.
The main way they work is by essentially trapping certain immune cells, called lymphocytes, in the lymph nodes.
So they keep them out of the brain and spinal cord?
Exactly. They prevent them from trafficking into the central nervous system and causing inflammation. Some, like fingolimod, might even have direct positive effects within the CNS, potentially helping with remyelination, but that's still being studied.
And efficacy. Let's use fingolimod as the example.
Sure. Fingolimod showed about a 50-52% reduction in annual relapse rate compared to placebo, and a 30% reduction in confirmed disability progression. It's also approved for pediatric MS and showed an impressive 82% lower relapse rate in kids compared to interferon beta-1a.
Sounds effective. What are the downsides, the safety concerns?
They do come with more significant safety considerations. There can be cardiac effects, like a slowed heart rate, particularly with the very first dose, so monitoring is needed. There's also a risk of macular edema, which affects vision, and an increased risk of certain infections, including rare but serious ones like PML or cryptococcal disease.
Anything else?
Yeah, VZV vaccination for chickenpox and shingles is required before starting. There's a risk of rebound MS activity if you stop the drug abruptly, and potential fetal harm means they're generally contraindicated in pregnancy.
What about vaccinations while on them?
Live attenuated vaccines are contraindicated, and vaccinations in general might be less effective. Sometimes drug interruption strategies around vaccination times are used to try and improve the response.
Okay, another important class, the anti-CD20s, like ocrelizumab.
Yes, the anti-CD20 monoclonal antibodies. These include ocrelizumab and ofatumumab. They are given as infusions or injections.
Yeah, and these are considered highly effective.
Very highly effective, typically with a rapid onset of action. Ocrelizumab is also uniquely approved for primary progressive MS, not just relapsing forms.
How do they work? What's CD20?
They are selitic monoclonal antibodies, basically. They target and destroy immune cells called B cells that have a specific marker called CD20 on their surface. We now understand B cells play a crucial role in MS, not just making antibodies, but also activating other immune cells and producing inflammatory signal.
And the results?
Impressive. Ocrelizumab showed a 46-47% reduction in annual relapse rates compared to interferon beta-1a, and a 40% reduction in confirmed disability progression. It reduced those enhancing lesions on MRI by 94-95%. Ofatumumab showed similar strong results against another oral DMT, teriflunomide.
Safety profile, what are the main concerns?
Key safety concerns include an increased risk of infections, particularly upper and lower respiratory infections and herpes infections. Rare cases of PML have occurred. There's also ongoing monitoring regarding a potential increased risk of malignancies, specifically breast cancer noted with ocrelizumab in trials, although the link isn't definitively causal yet. Hepatitis B screening and checking immunoglobulin levels are needed before starting.
Pregnancy and vaccines.
Generally not recommended in pregnancy, as they can cross the placenta and cause temporary B-cell depletion in infants, and they are expected to significantly interfere with vaccine effectiveness because they deplete the very cells that make antibodies. We saw this clearly with reduced responses to COVID-19 mRNA vaccines in people on ocrelizumab.
And finally, let's touch on natalizumab again from our opening story.
Right, natalizumab. Given as an intravenous infusion, known for rapid control of highly active relapsing MS.
How does it work?
It's a monoclonal antibody that binds to something called alpha-4 integrins on immune cells. This blocks those cells from sticking to and crossing the blood-brain barrier to get into the central nervous system.
Effectiveness.
Highly effective. Showed a 67% reduction in annual relapse rate versus placebo, and a whopping 92% reduction in those gadolinium-enhancing lesions on MRI.
And the big safety concern we mentioned.
The primary concern is the risk of progressive multifocal leukoencephalopathy, PML, that rare but often fatal brain infection.
But manageable with testing.
Yes. The risk is almost entirely confined to patients who test positive for the JC virus antibody. So, testing before starting and regularly during treatment is absolutely critical. There's also evidence that extending the dosing interval, say to every 6 weeks instead of every 4, might further reduce the PML risk without losing too much efficacy. There's also a strict monitoring program called REMS in place.
Other risks.
Uncommon but severe liver toxicity can occur, and like some others, abrupt discontinuation can lead to rebound MS activity, sometimes quite severe.
Pregnancy and vaccines.
Not generally recommended in pregnancy, though some small studies suggest continuation through the first trimester might be considered for very highly active disease. It is detectable in breast milk. And like other potent DMTs, it can lead to inadequate vaccine responses in some studies. Live vaccines aren't recommended during treatment.
Wow. So after diving into just a few of these powerful DMTs, the key insight here seems crystal clear. There's no single best treatment for everyone, is there?
Not at all. It's a constant, very personal calculation. You're weighing how powerful a drug is at controlling the disease against its potential risks and side effects, how it fits into your life.
It's a strategic decision that really needs to evolve with your disease, your risk tolerance, your life stage, everything.
Exactly. It's a testament to how far we've come in treating MS, offering so many options. But it also shows just how complex these choices remain.
Indeed. And for some patients, especially as they get older, the conversation sometimes shifts, doesn't it?
Yeah.
It turns to whether to continue these powerful therapies indefinitely. What factors come into play there?
That brings us to the concept of immunosenescence.
Which is?
It refers to the natural aging of our immune system. As we get older, our immune function tends to decline. In older individuals with MS, this can kind of do two things simultaneously.
Okay.
It can increase the risks associated with immunotherapies, but it might also reduce the inflammatory activity of MS itself, as the disease often becomes less inflammatory, less relapse-driven with age.
So the risk-benefit balance might shift.
Precisely. Given these safety concerns in aging MS populations, potentially waning efficacy of some DMTs in older adults, and frankly, the massive cumulative cost of decades of immunotherapy, evaluating when and how to potentially discontinue treatment is a really active and important area of study right now.
What does the current evidence suggest?
Well, retrospective studies, again, looking back at data, suggest that patients 45 years and older who discontinue their DMT after a good period of stability are more likely to remain stable compared to those younger than 45. Younger patients seem to face a higher risk of having new attacks or seeing new activity on their MRI if they stop.
Is there research looking at this prospectively?
Yes, there's a very important ongoing study called DISCOMS. It's a real-world study specifically evaluating randomized DMT discontinuation. So, carefully stopping the drug under supervision in patients aged 55 and older who have had at least 5 years of stable disease.
That sounds crucial.
It really is. The results of DISCOMs are highly anticipated and will provide invaluable guidance for patients and providers wrestling with this very question: when and for whom is it safe to consider stopping DMTs later in life?
Okay, let's pivot now. We've talked a lot about treating the underlying disease with DMTs, but what about managing the day-to-day reality of living with MST? This brings us to segment 2. Living with MS, holistic symptom management and wellness. And this is incredibly important, isn't it? Symptomatic management is often just as impactful to a person's quality of life as their DMT choice.
That's absolutely right.
Yeah.
While DMTs target the underlying disease progression, trying to slow it down, symptomatic management aims to maximize your function, your independence, and your overall well-being right now.
It's not just about stopping future attacks. It's about enabling you to live a full and meaningful life with MS today.
Precisely. And this truly requires a comprehensive team approach. It involves your medical specialists, yes, but also rehabilitation experts like physical therapists, occupational therapists, your family, and even community support systems.
Are there challenges in this area compared to DMTs?
There are. It's important to acknowledge, for example, a relative scarcity of large, head-to-head randomized controlled trials for many commonly used symptomatic treatments, partly because some have been used for so long, and there's an ongoing need for efficient methods to monitor symptoms effectively over time, beyond just asking, "How are you doing?"
So when a patient comes in reporting new or worsening symptoms, how does a provider figure out what's really going on? Is it definitely a relapse, or could it be something else that needs a different approach?
This is a critical first step, distinguishing between true exacerbations or relapses and what we call pseudo-exacerbation.
To break that down, true exacerbation means?
A true exacerbation indicates new central nervous system inflammation, a new lesion or reactivation of an old one. It's the MS itself flaring up.
And a pseudo-exacerbation?
That's an acute worsening of your baseline MS symptoms you already have, but it's triggered by some kind of stressor. Things like an infection, maybe significant emotional stress, or even just getting overheated. The key is there's no new underlying inflammation in the brain or spinal cord causing it.
So the symptoms feel very real and disruptive, but the cause isn't a new MS attack. How do you figure that out in the clinic?
Exactly. A common and really crucial first step for any acute worsening of symptoms is a simple urine dipstick test, often followed by a urine culture if the dipstick is positive.
Why urine specifically?
Because urinary tract infections, UTIs, are surprisingly frequent triggers for pseudo-exacerbations in people with MS. They're very common.
So treating the UTI might be enough?
Often, yes. Treating the underlying trigger, like the infection, may be sufficient to alleviate the worsening symptoms. This helps avoid the unnecessary use of powerful medications like corticosteroids, which have their own side effects. Symptomatic therapy given for a pseudo-exacerbation should ideally be prescribed for shorter periods, with the expectation that the need for it will diminish as that underlying trigger resolves.
Now, what about those symptoms that aren't immediately obvious during a clinical exam? The ones often referred to as invisible symptoms. These can be some of the most challenging to live with, can't they?
Oh, absolutely. Invisible symptoms, think fatigue, cognitive impairment or car fog, chronic pain, sexual dysfunction. These are unfortunately often underreported and therefore undertreated, yet they have a massive negative impact on quality of life.
So how do you get at those? How do you make sure they're addressed?
Yeah. To truly understand their impact, simply asking any other problems isn't enough. You really need to augment a routine symptom review with targeted questions. And using patient-reported outcome measures, validated questionnaires, is crucial for screening and monitoring these effectively over time.
Can you give an example, like with sexual dysfunction?
Sure. Sexual dysfunction can affect a surprisingly high number of people with MS, maybe 40% up to even 90% in some studies. It helps to first normalize the topic by mentioning how common it is. Then you can gently ask specific questions about its onset, how it relates to their MS, and specific areas like changes in sex drive, arousal issues like erection difficulties or vaginal moisture, or changes in orgasm ease or satisfaction. That open, non-judgmental dialogue is absolutely key.
It's also important to understand that symptoms don't always occur in isolation, right? They often seem to cluster together.
That's a great point. Awareness of these symptom clusters helps identify underlying causes, which allows for optimal, often multifactorial treatment. And importantly, it can help limit polypharmacy taking too many different medications.
Why do they cluster?
Well, symptoms often cluster for a few reasons. They might share common origins in the nervous system, the same damaged pathway causing multiple issues. There can be secondary effects where one symptom directly influences or worsens another, or sometimes it's iatrogenic causes,
Meaning caused by...
caused by the medications themselves. Side effects. For instance, sexual dysfunction might cluster with upper body weakness or spasticity if it's due to primary spinal cord lesions. But it could also be secondary to pelvic floor muscle issues or cognitive symptoms interfering.
Or the meds.
Or it can be caused or worsened by medications like baclofen, a muscle relaxant, certain antidepressants like tricyclics or SSRIs, NRIs, or even drugs like amantadine or amphetamines used for fatigue. These can contribute to decreased libido or erectile dysfunction.
So a medication prescribed for one symptom could inadvertently worsen another or even create a new one. That sounds like a really challenging cycle for both patients and providers to navigate.
It absolutely is. Another really common cluster is poor sleep, fatigue, and nocturia. That's frequent nighttime urination. This is often linked to a neurogenic bladder, meaning bladder control issues caused by nerve damage from the MS.
And that can be worsened by other things too.
Yes, things like alcohol, opioids, or certain antidepressants can make that neurogenic bladder worse. Even commonly used muscle relaxants, certain anticholinergic drugs, and even cannabis products can inadvertently increase your fall risk, adding another layer of complexity. Recognizing these clusters allows for a much more targeted and holistic treatment approach.
Are there programs that help with these clusters?
Yes, online self-management programs like MIMS Toolkit have been developed specifically to address that common and debilitating cluster of pain, depression, and fatigue, offering strategies to manage them together.
How do other health conditions, comorbidities, and just the natural process of aging fit into this whole picture of symptom management?
They fit in significantly. Comorbid conditions, other health problems alongside MS, like vascular diseases, high cholesterol, hypertension, diabetes, or depression, or even tobacco use, can actually accelerate disability progression in MS. They can also negatively impact cognitive processing speed.
It's like a double hit.
It really can be. And conversely, cognitive difficulties might reduce a person's participation in social activities or exercise, which then can worsen those comorbidities. It's a vicious cycle sometimes.
What about sleep? You mentioned it briefly.
Poor sleep is a major culprit. It aggravates fatigue, cognitive dysfunction, depression, and anxiety, all common MS symptoms. A helpful screening question I often use to try and distinguish general tiredness from MS-related fatigue is, do you wake up tired?
How does that help differentiate?
If the answer is yes, I wake up feeling tired, it often suggests a primary sleep-related issue, like maybe sleep apnea, which needs investigation, whereas classic MS-related fatigue often hits more acutely in the mid-afternoon, even if sleep is okay.
So managing those other health conditions is crucial for managing MS symptoms too.
Absolutely essential. Partnership with your primary care doctor for aggressive treatment of all comorbid diseases is a necessary part of comprehensive MS symptom management.
And does symptom management stay the same over time?
No, definitely not. Symptom management treatments require periodic reevaluations. Symptoms themselves can fluctuate, and the impact of aging and those other health conditions can change over time. Sometimes periodic dose reductions for medications are necessary to limit polypharmacy taking too many drugs and to reduce potential cognitive side effects from the cumulative burden of medications. You always have to reassess.
So let's say someone has mild or early symptoms. Before jumping to medication, what's the first line of defense? Is it just education?
For many patients, especially early in the disease course or when symptoms are mild, education alone can be incredibly helpful, sometimes even sufficient for a while. Just understanding the origin of the symptom, its prevalence in MS, its natural history, that can be empowering.
Where can people find good information?
Valuable online resources like the National Multiple Sclerosis Society, nationalsociety.org, and the Multiple Sclerosis Association of America, mimemsa.org websites offer comprehensive, reliable information. They also connect people to support groups, which can be incredibly valuable.
And beyond just education, supporting healthy lifestyle habits seems absolutely foundational, doesn't it? It's about empowering patients to manage aspects of their condition proactively themselves.
It is absolutely foundational. This includes encouraging healthy food consumption, regular exercise, good sleep hygiene, effective stress management practices, and minimizing negative influences like excessive alcohol and tobacco use.
Let's talk diet. Dietary studies are notoriously difficult, right? But what do we know about diet and MS?
You're right, they are hard to conduct rigorously, but when you look across various interventional diets that have shown some promise, things like a modified Mediterranean diet, calorie restriction or intermittent fasting, ketogenic approaches, modified Paleolithic, even low-fat diets, some common themes emerge.
Like what?
An increased intake of fruits and vegetables, a reduction in processed foods and refined sugars, and a preference for whole grains over refined ones. They seem to be common threads.
And what symptoms seem to improve most with dietary changes?
Fatigue is the symptom most frequently reported as improved in these dietary studies. Some patients also report improvements in emotional well-being, and even occasionally in things like hand dexterity. Importantly, these dietary interventions also consistently improve biometric data like cholesterol, blood sugar, blood pressure, which helps lower the risk of those vascular comorbidities we talked about.
Who can help people navigate dietary changes?
Registered dietitians are invaluable members of the MS treatment team. They can provide personalized guidance and practical strategies tailored to the individual's needs and preferences.
Okay, that's diet. What about exercise? It feels like it should be beneficial, but often people with MS worry about overheating or just overdoing it, triggering symptoms.
That's a common and valid concern, but the evidence for exercise is really compelling. It demonstrably reduces MS fatigue, one of the most common and disabling symptoms. It improves overall health markers, like cardiovascular fitness. And quite encouragingly, emerging evidence suggests it may even improve cognitive performance in people with MS.
So how do you address those concerns about overdoing it or heat?
It's crucial to address them directly. Referring patients to physical therapy is key. A physical therapist experienced with MS can design tailored exercise routines and teach appropriate titration, how to gradually increase activity safely, managing heat sensitivity with cooling strategies if needed. They ensure people build up activity safely and effectively.
Have the recommendations changed recently?
Yes, updated recommendations have broadened the definition of exercise to include general lifestyle physical activity, just moving more throughout the day, and they've increased the recommended weekly time slightly, from 120 to 150 minutes per week, making the goals perhaps more attainable across the spectrum of MS disability.
Can exercise be tailored to different levels of disability?
Absolutely. Exercise strategies can and should be highly tailored based on a patient's expanded disability status scale, EDSS score, which measures their level of disability. This can include specific types like aerobic, resistance, flexibility, and neuromotor exercises, like balance and coordination for various levels of impairment, right through to breathing and flexibility exercises for those who are non-ambulatory. There's something beneficial for almost everyone.
Beyond the physical diet and exercise, emotional well-being is clearly a huge part of living well with MS. It's not just about the body.
Not at all. The mind and spirit are just as important. Practices like yoga, tai chi, meditation, and even acupuncture, although they might have fewer large-scale randomized controlled trials specifically for MS outcomes, are generally low-risk and highly acceptable options for promoting emotional well-being. They're definitely worth exploring as complementary approaches.
And social support.
Vital. Support groups, maintaining social interaction, engaging in activities like volunteering, and seeking counseling when needed are all crucial for fostering a sense of community, reducing isolation, and supporting mental health.
You mentioned something interesting earlier about doctors giving written prescriptions for lifestyle changes?
Yes. Research shows that when trusted physicians give verbal recommendations about healthy lifestyles like diet, exercise, sleep, and then follow that up with a concrete written prescription for specific actions like stretch for 10 minutes daily, practice sleep hygiene called the smoking cessation hotline.
It's more effective.
Much more effective at promoting actual behavioral change than just handing out a printed brochure alone. It seems to lend an air of importance, personalization, and commitment. It makes it feel more like a core part of the treatment plan.
That makes sense. It's about making it concrete and personal, a true partnership. I remember reading about a patient in the source material, the 38-year-old woman recently diagnosed.
Yes, I recall that case.
She had leg tightness, cramps, fatigue, urinary urgency. But her MRIs were stable. When her provider educated her about the likely origins of her symptoms, how they clustered together related to her specific spinal cord inflammation.
And framed it within the context of stable disease.
Exactly. She expressed such relief just understanding what was happening. And interestingly, she didn't even want medicine for those symptoms at that point. She chose to focus on stretching, improving sleep hygiene, and quitting smoking first.
That's an excellent example. That proactive approach from her provider, educating her and guiding her towards community resources and self-management strategies, was key. It empowered her.
It really shows how education and support of healthy lifestyle habits can be the foundation of MS symptom self-management. It allows patients to prioritize and take those steps themselves first.
And then the provider can reassess later which symptoms, if any, still require further intervention. It's about informed choice and starting with the least invasive options first.
Okay, moving beyond lifestyle interventions, what about specific non-pharmacologic treatments? Things delivered by therapists, for example. When would those come into play?
These non-pharmacologic symptomatic treatments for MS offer that significant advantage of avoiding the systemic side effects that can often come with medications. Side effects which can sometimes exacerbate other MS symptoms like fatigue or cognitive issues.
What kind of therapies are we talking about?
A wide range. Physical therapy is huge, covering pelvic floor issues, vision therapy, balance training, strength training, gait training, recommendations for assistive devices like canes or walkers. Then there's occupational therapy, focusing on adapting daily activities and tasks.
What else?
Speech therapy, which also often addresses swallowing and cognitive issues, driving evaluations to ensure safety behind the wheel, social work referrals for accessing resources, counseling and family therapy for emotional support, specialized multidisciplinary pain centers, even palliative care.
Which sometimes has a negative connotation, but shouldn't.
Exactly. Framed positively, palliative care is about maximizing services for comfort and quality of life at any stage, providing crucial symptomatic and emotional support, especially for those with more advanced disability.
What about integrative health practices, like acupuncture?
Things like acupuncture, often used for pain and spasticity, or perhaps aquatic exercise or mindfulness techniques for issues like sexual dysfunction, are increasingly studied. While some might have limited strong evidence from large randomized trials compared to drugs,
They might still be worth considering.
yes, their generally low-risk profile and high patient acceptability make them worth considering for many individuals as part of a broader plan. Though, admittedly, cost and insurance limitations can sometimes be barriers to accessing these therapies.
Okay. When we do turn to pharmacologic treatments medications specifically for symptoms, are there any actually approved by the FDA for MS symptom management, distinct from the DMTs we talked about earlier?
Yes, there is one. Dalfampridine. It's currently the only FDA-approved agent specifically for MS symptom management. Its official indication is to improve walking speed.
Just walking speed.
That's the official indication, but emerging evidence suggests its benefits might be broader. Studies hint at improvements in walking duration, self-reported walking ability, even finger dexterity, cognitive function, fatigue reduction, mood improvement, and better balance.
So potentially quite versatile. Are there risks?
It does have contraindications. Specifically, a history of seizures is an absolute no, and it shouldn't be used in people with significant kidney impairment, low creatinine clearance. And for older patients, a periodic reevaluation, maybe trying a 2-week drug holiday off the medication, can be prudent to ensure it's still providing benefit and to assess for any emergent side effects that might have crept in.
What about really common drugs used off-label for things like muscle spasticity? Are those well supported by evidence and investigation?
Well, for muscle spasticity, medications like baclofen, tizanidine, and gabapentin are very, very commonly used. They've been around for a long time and are widely prescribed based on clinical experience.
But the trial data.
It's worth noting that high-quality randomized controlled trials, specifically in MS populations, are surprisingly limited for these particular agents, largely because of their long-standing use before current trial standards were common. Their inclusion in treatment recommendations is mainly based on expert opinion and that widespread clinical experience over decades, rather than robust modern trial data comparing them head-to-head in MS.
Interesting. Now let's talk about a topic that comes up a lot in patient discussions. Cannabis and cannabinoids. There's just so much public interest, but also conflicting information out there. What does the evidence actually say for MS symptoms?
That's a really common question. There is definitely growing evidence, but crucially, there is no FDA approval for any cannabis product for MS symptoms here in the United States.
Can you explain the basics? THC versus CBD.
Sure. Cannabis contains various active compounds called cannabinoids. The main ones people talk about are THC, that's tetrahydrocannabinol, the primary psychoactive or intoxicating component, and CBD, cannabidiol, which is generally considered non-intoxicating.
Is there a specific product that's been studied most for MS?
Yes, the most studied product globally for MS is Nbiximols. It's an oral spray with a roughly 1-to-1 ratio of THC to CBD. It is approved in many other countries specifically for treating MS spasticity, but not in the U.S.
So, What do reviews of the evidence say, like from the American Academy of Neurology?
Reviews by the AAN and others indicate that there is high-quality evidence supporting a modest reduction in patient-reported spasticity symptoms with cannabinoids, particularly nabiximols.
Okay, so some benefit for spasticity. But what are the concerns? What should people be aware of, particularly with chronic use?
The greatest concern, particularly with chronic use of cannabis products containing significant amounts of THC, is cognitive impairment.
Cog fog.
Yes. Studies have shown that chronic cannabis users with MS often perform more poorly on objective cognitive tests compared to non-users. Interestingly, one study found that chronic cannabis smokers with MS who completely abstained for 28 days actually demonstrated measurable improvements in memory, processing speed, and executive function.
So stopping helps their thinking.
It seemed to in that study. However, to show the complexity, another study looking specifically at nabiximols that prescribed 1.1 spray actually found improvements in processing speed and auditory verbal memory in patients using it.
So it's complicated. Different products, different effects.
Exactly. It highlights the complexity. The specific formulation, the ratio of THC to CBD, the route of administration, smoking versus spray versus edibles likely all play a role. More research is definitely needed to fully understand the risks and benefits here. It's vital that patients discuss any cannabis use with their healthcare team and are directed to independent, evidence-based resources like the website cannabisevidence.org, rather than relying on anecdotal reports or dispensary advice alone.
Good advice. What about other medical procedures for symptom management? Are they always considered a last resort? Or are there times when they might actually be a better first choice than, say, adding another oral medication?
That's a really important point. While they're often listed under advanced therapies, implying they are a last resort, some high-evidence and relatively low-risk medical procedures can actually offer a more favorable risk-benefit profile precisely because they avoid the systemic side effects of oral medications.
Like what, for example?
A prime example is onabotulinum toxin A injections, Botox. It's FDA approved for conditions highly relevant to MS, like urinary incontinence resulting from neurogenic bladder, and also for upper or lower limb spasticity.
How long does it last for bladder issues?
Its efficacy for bladder control can last up to 9 months from a single treatment session.
So considering that early could avoid other meds.
Exactly. Early consultation with a specialist who performs these injections, like a urologist for bladder issues or a neurologist or physiatrist for spasticity, can potentially significantly reduce or maybe even eliminate the need for patients to take multiple daily oral medications that often carry those unwanted CNS side effects like fatigue, dizziness, or cognitive impairment. The goal should always be to clearly communicate all the options, including procedures, that might minimize the burden of taking multiple oral agents.
Okay. And then what about those systemic therapies or procedures that might have lower evidence supporting their use specifically in MS, or perhaps carry higher risks overall?
Right. So for fatigue, for instance, commonly used stimulant-like agents such as amantadine, modafinil, and methylphenidate, when they've been rigorously tested in randomized controlled trials specifically for MS-related fatigue.
What do the trials show?
They have often not been found to be superior to placebo. And sometimes they actually had higher rates of adverse events than the placebo group.
So they might not work that well for MS fatigue and could cause side effects.
That's what the best evidence suggests. This should definitely temper expectations for using them as a first-line approach for MS fatigue, especially given the side effect potential. It really highlights the ongoing need for more high-quality comparative trials to establish truly robust, evidence-based guidelines for many MS symptomatic therapies. We need better data.
Let's talk vitamin D. It seems to be a hugely popular supplement everywhere, not just in MS. What's the specific take here, given what we know about MS risk and progression?
Vitamin D is likely the most common supplement used by people with MS, and there's a reason for the interest. Observational studies looking at populations do consistently link higher naturally occurring vitamin D levels to a lower risk of actually developing MS in the first place. And in people who already have MS, higher levels are often associated with fewer relapses and less new active inflammation seen on MRI scans.
Okay, so higher levels seem protective. Does taking supplements after diagnosis help?
That's the key question. And robust scientific reviews, like Cochrane reviews, have looked at the randomized trials of vitamin D supplementation in people already diagnosed with MS. They've found only low-quality, direct evidence, unfortunately, of a significant impact on relapse rates or disability progression from actually taking vitamin D supplements once you have the disease.
So the link is there, but supplementing doesn't clearly change the disease course.
Based on current high-level evidence, that seems to be the case. However, the good news is that high doses of vitamin D have generally been well tolerated in studies. So, while it might not be a powerful disease modifier, ensuring adequacy is still reasonable.
What dose is generally considered sufficient?
Generally, daily oral doses of 2,000 to 4,000 international units, IU, of vitamin D3 are considered sufficient for most adults to maintain optimal serum levels, though testing levels periodically is still a good idea.
And speaking of supplements, the source material had that really fascinating, maybe slightly alarming anecdote about a patient taking a very, very long list of dietary supplements they found online for their MS. What are the general concerns with supplements, especially given how widespread their use is?
This is a huge area of caution. Use of non-prescription dietary supplements is incredibly widespread, reported by up to 80% of MS patients in some surveys. The key issue is twofold. First, they generally have very low evidence of actual efficacy for MS symptoms or disease modifications.
And second,
Perhaps more importantly, there is very little FDA safety oversight for supplements compared to prescription drugs.
what does that mean in practice?
Unlike prescription medications, the FDA doesn't require supplement manufacturers to conduct pre-market safety or efficacy testing, so potential adverse events might only be discovered much later, perhaps during clinical trials conducted for other purposes, or sometimes only through individual case reports after people have already experienced harm.
Can you give examples?
Sure, trials have linked certain supplements like high-dose lipoic acid to potential kidney issues, nephropathy. Green tea extract has been associated with liver toxicity in some cases. Even seemingly benign things like calcium supplements have been linked to kidney stones and even potentially heart attacks in some large studies, particularly in older adults.
Wow, so natural doesn't automatically mean safe.
Not at all. It's absolutely vital for patients to discuss all supplements they are taking or considering taking, including over-the-counter options, herbal remedies, everything with their healthcare providers. And ideally, they should be referred to a registered dietitian who can help assess the actual need for supplementation based on diet and labs, and crucially, help avoid potential harm or interactions with their prescribed MS medications or other drugs.
That example of the patient with a complex list of supplements found on the internet really underscores the challenges, doesn't it? And the critical need for open, honest discussion with providers.
Absolutely. Always tell your doctor and pharmacist everything you're taking, even if you bought it at a health food store or online. Transparency is key to safety.
Okay, one last category here. Higher risk medical procedures for symptoms. When are those typically considered?
These procedures, things like intrathecal baclofen pumps, which deliver muscle relaxants directly into the spinal fluid via a surgically implanted pump.
For severe spasticity.
Exactly. Or chemical denervation procedures, sometimes surgical procedures like rhizotomies, cutting specific nerve roots, or tendinectomies for severe contractures. Maybe things like suprapubic catheters for long-term bladder drainage, or even spinal cord stimulators for certain types of pain. These are typically considered only after less invasive pharmacotherapies have failed to provide adequate relief.
Why only then?
Because they carry inherent risks of infection, bleeding, hardware malfunction, the need for ongoing maintenance or repeat procedures. They represent the more aggressive end of the symptomatic management spectrum, generally reserved for situations where other options are no longer effective and the symptom burden is extremely high.
It really sounds like managing MS, both the underlying disease progression and all these potential daily symptoms, is just a continuous act of prioritization, doesn't it? Given how many symptoms can manifest, how do providers realistically manage to review everything effectively at each visit? It seems overwhelming.
It certainly can be overwhelming for both the patient and the provider. It's definitely impractical and probably unnecessary to try and conduct a comprehensive review of every single possible symptom at every single visit.
So what's a more practical approach?
A strategy many clinicians use is the top 3 approach. Asking the patient, what are the top 1, 2, or 3 things bothering you the most right now since our last visit? This helps prioritize the discussion on what's currently most impactful to their quality of life.
What about using tools to help track things?
Utilizing those patient-reported symptom measures, we talked about questionnaires for fatigue, cognitive impairment, pain, mood, etc., and integrating objective performance measures like timed walking speed or hand dexterity tests directly into the electronic medical record can significantly streamline the process. It allows for ongoing monitoring between visits and provides objective data points.
Are there quality metrics related to this?
Yes, there are recognized MS quality metrics that encourage clinicians to consistently screen for common but often overlooked issues like bladder, bowel, and sexual dysfunction, cognitive impairment, fatigue, and also to provide exercise counseling. Focusing on these key areas helps ensure comprehensive, patient-centered care without necessarily needing to cover every single possibility at every single appointment. It's about being systematic and targeted.
This has been an incredibly insightful journey through the complexities of MS management. We've covered so much, from the high-tech DMTs to the crucial foundations of holistic care. To really bring home the impact, let's take a moment now for segment 3, Voices of Experience. Let's hear directly from some individuals whose experiences really resonate with the very topics we've explored today.
Absolutely. These voices offer such a powerful perspective, grounding the clinical information in the real-world impact of these treatment decisions and the day-to-day journey of living with MS.
First, let's hear a reflection from that young man in our cold open. This touches on his initial cautious approach and how the relationship with his care team evolved.
Okay. Patient voice 1. Despite extensive discussion of the potential risks of permanent neurologic disability from MS, he and his parents preferred an escalation approach, prioritizing safety over efficacy. However, the strong therapeutic alliance that had developed, between the patient and provider resulted in acceptance of an initially feared treatment. And this next voice captures that profound power of just understanding and the role of self-management, sometimes even without medication. This is from that 38-year-old woman we discussed who chose lifestyle changes first.
Right, patient voice 2. The patient expressed relief, just understanding the origins of her MS symptoms, and stated she did not want to take medicine for the symptoms right then. And here, a very direct experience with finding the right balance for symptom relief, specifically about adjusting medication dosage carefully and seeing real benefits.
Yes. Patient voice 3, at follow-up, the patient reported sharper thinking, feeling steadier on his feet, and having less nighttime dysesthesia. That tingling. And finally, let's hear an insight from an MS specialist, distilling a crucial lesson learned from patient journeys, especially regarding symptom changes. MS Specialist Insight 1. This case highlights the importance of searching for medical and iatrogenic causes, medication side effects, for what can appear to be worsening MS symptoms that might otherwise be mistakenly attributed to a transition from relapsing to secondary progressive MS.
Wow. What stands out to you from hearing those voices again? For me, it's really that interplay between the clinical data, the patient's own preference and experience, and the absolute critical need for an ongoing, trusting relationship with one's care team. It truly is a dance, isn't it? A partnership.
Yes, it truly is. The patient's perspective, their lived experience, their understanding of their own symptoms, and the impact that treatments or even deciding not to treat with medication have on their daily lives, that has to be paramount. It's a dynamic process of assessment, adaptation, and true partnership, always.
So to bring it all together as we wrap up, what does this all mean for you listening today? MS management is truly a sophisticated interplay, isn't it? Between those powerful disease-modifying therapies which aim to control the underlying disease activity.
And those equally vital strategies for managing the day-to-day symptoms, the things that significantly enhance quality of life. Optimal care, as we've heard again and again, really emphasizes a patient-centered, shared decision-making approach.
It's a journey that is anything but static. Living with MS is dynamic. It requires ongoing assessment, ongoing adaptation of both the disease-modifying and the symptomatic treatments, always keeping a strong focus on overall wellness.
It really is about living well every single day despite the challenges MS presents.
So, for our actual takeaways from today's deep dive, here are 3 key things you can carry forward and perhaps apply to your own journey or the journey of someone you care for.
Okay.
First, prioritize that shared decision-making with your MS provider. Go into your appointments ready to discuss your values, your preferences, what matters most to you. Ensure you align on treatment goals, whether for disease modification or symptom management, making sure your values are truly central to the strategy.
Second, embrace healthy lifestyle interventions. Don't underestimate their power. Tailored exercise, optimized nutrition, practices for emotional well-being, things like mindfulness or yoga, these are foundational elements for managing MS symptoms and have a powerful, often underestimated impact on your quality of life. Start small, aim for consistency. It adds up.
And third, and this is so critical, always discuss all medications and supplements you are taking, including over-the-counter options, herbal remedies, everything, with your entire healthcare team, your doctor, your pharmacist. This transparency is absolutely crucial to avoid unintended side effects or interactions and ensures you're on the safest, most evidence-based path for your specific needs. No detail is too small to mention.
And a final thought to leave you with. As we continue to gain more and more insights into the complexities of MS, how might integrating personalized information, maybe even genetic information down the road, further refine this delicate balance between aggressive disease suppression and holistic well-being? Could this pave the way for truly bespoke, truly individualized care plans in the future? It's a powerful question to ponder for the future of MS care.
That's a really powerful thought to consider. The future of MS care truly does seem headed towards even greater personalization. We really encourage you to continue your learning journey. You can find links to the source material for this deep dive, including those PDFs on relapsing MS pharmacologic interventions and holistic symptom management in MS, right in our show notes.
And we'll also include links there to additional resources for MS support, such as the National Multiple Sclerosis Society, the Multiple Sclerosis Association of America, MIMS Toolkit for self-management, Exercises Medicine for finding qualified professionals, and that evidence-based cannabis resource, cannabisevidence.org.
Thank you so much for joining us on this deep dive into multiple sclerosis.
It's been a pleasure. Thank you.
Until next time, stay curious and keep digging deeper.